Thank you, Heather, and good evening. Thank you all for coming out on a rainy and chilly evening tonight. And even though you've heard the names, let me make sure you know who's who. We have Dr. Jatin Shah, who is the chief of the Head and Neck Service, and head and neck surgeons, Dr. Snehal, Patel, and Dr. Ian Ganley here. And welcome, gentlemen. One more thing about housekeeping is when you write out the questions for you, do me a favor, because based on past experience, many of you are frustrated physicians, which means your handwriting is really awful, and I'm going to have to read it. So please try to write it out as clearly as you can. So usually in our Cancer Smart panels, we focus on a cancer that occurs in a particular organ, like pancreas, liver, breast, or prostate, for example. And one of the first things we usually convey during these panels is that the tumors that occur in these organs are actually many different types of cancers. Head and neck cancers are a little bit different in that we're talking about cancers that occur in an entire region of the body. And we've always known that there are a wide variety of cancers included in what we refer to as head and neck cancers. There are about 48,000 head and neck cancers diagnosed every year in this country. That doesn't include skin cancers. In this country, and they can occur in such areas as the throat, the larynx, or the voice box, nose, sinuses, mouth, and thyroid. And part of what makes head and neck cancers challenging is that, as I learned in medical school, there really is about as much anatomy going on from the neck up as there is pretty much in the whole rest of the body. And even more challenging is that the structures that were in the head and neck that we're talking about are such a big part of who we are and what we do as human beings, talking, breathing, chewing, swallowing, not to mention, of course, what we look like. So tonight we'll discuss some of the most common head and neck cancers, their risk factors, causes, and symptoms, and we'll also describe treatment options, including the trend towards less invasive surgery, of course, to minimize disability and preserve function. And along those lines, we'll also cover reconstruction and the quality of life after head and neck surgery. And finally, we'll also describe the team approach to cancer treatment here at Memorial Sloan Kettering. And that means bringing together the best people in surgery and radiation and research to ensure that patients benefit from the very latest and best treatment options, something that is especially true when it comes to clinical trials, which we'll also discuss tonight. So let me begin. We're going to begin, and I'm going to ask each of our panelists to give us a little brief rundown on their areas of expertise and interest here. Then I will direct some questions to them. We'll talk for about an hour or so, and then we'll take questions from you for about the last half hour or so. So Dr. Patel, as the chief, why don't you get started? Oh, I'm sorry. I said Dr. Patel. I meant Dr. Shah.
I don't know if it's...
It's been
I did not realize Snehal was promoted to be the chief.
Yeah, well, no, I'm not going to do that. Dr. Shah, I apologize.
That's all right. Max, head and neck is, as you said, a very complex part of the human anatomy. The central processing unit, brain, CPU of the human body, connects to the rest of the systems through head and neck. And therefore, all the diseases and disorders that occur in the head and neck has some degree of functional impact. Either it will impact your ability to speak, to swallow, to express yourself, to see, your vision, your sense of smell, your ability to hear, your ability to articulate. And therefore, the treatment algorithms we develop not only keep cure of the disease in mind as the first goal, but a very parallel and competing goal is the preservation or restoration of form and function. And that's the focus of modern day treatment in head and neck cancers.
Now, Dr. Patel, I know you were chief for about 5 seconds there, but go ahead and tell us a little bit about your area.
I'm not sure it felt good while it lasted, but so I think as Dr. Shah just mentioned, the goal of treatment for these kinds of cancers is not just to achieve control of the cancer, but also to restore the person back to where they started before the cancer was diagnosed. And that means taking into account their form, function, and quality of life. So a lot of the work that we do nowadays is to first understand what influences quality of life as we know it, and then devise measures to minimally impact on those issues while not compromising on the ability to control the cancer.
Very good. Dr. Ganley, you're up.
Well, the traditional approaches for treating head and neck cancer up until 10 years ago were with open surgical procedures, many of which resulted in significant morbidity with regards to speech and swallowing, as Dr. Patel and Dr. Shah have mentioned. So my particular interests are in developing more minimally invasive operations and techniques to try and reduce this type of morbidity.
Well, now, when you say morbidity, people sometimes think that means death, but you mean this is sort of an impacting...
Impact on quality of life.
Right.
And in head and neck, that really applies to speech and swallow and cosmesis.
Their appearance.
Yes, yes. The minimally invasive techniques which I'm referring to are really the introduction of laser surgery, endoscopic laser surgery, and also the introduction of robotic surgery for head and neck cancers, endoscopic surgery as applied to cancers of the sinuses.
Mm-hmm. Good. So we're going to get into that in some more detail, but why don't we start out now with some sort of defining a little bit about what we're talking about. So Dr. Shah, tell me what is included in head and neck cancers?
It's a huge repertoire. Anywhere from skin to the spinal cord and from the lips to the esophagus, implying head and neck cancers under that common name or label include cancers that develop in the skin, your scalp, in the mouth, in the throat, in your voice box, larynx, in your swallowing passage, pharynx, in your salivary glands, in your thyroid gland, and the soft tissues and bones which compose the head and neck, meaning the muscles, the fat, the nerves, and the bones of the sinuses, and base of the skull, and the skull itself. So it's a huge variety of tumors. If we numerically go about it, there are 17 different types of tumors that arise in the head and neck area, and each of them have a very different biological behavior. So to develop a treatment algorithm, we are talking about a variety of different algorithms for each tumor or each tumor system that develops. Even the causative factors for these are different. Tumors that occur in the mouth or throat are mostly related to consumption of tobacco and alcohol. Tumors that arise in the skin cancer, basal cell carcinoma, melanoma, have sun exposure as a possible causative factor. Exposure to radiation is another factor that leads to development of thyroid cancer. There are some genetic predispositions. Women who have had breast cancer have a higher risk of developing tumors of the salivary glands and vice versa. So all of these have to be factored into the specialty of head and neck surgery. It's a very complex field.
You pretty much cover everything we're going to talk about in the next hour and a half there. So, but let's deal with some more of those things a little bit more deeply in some detail. So, Dr. Patel, as Dr. Shah said, 17 different cancers. They're not just occurring in different spots in the head and neck. These are actually different cancers that require different treatments and approaches even beyond the surgical removal?
Yes, absolutely. I think it's a great tumor system, if you will, in terms of the variety and complexity that physicians face. It's when Dr. Shah mentioned 17 different types, it's not just the anatomic sites, but also the different types of tumors. For instance, the smoking and alcohol-related tumors are squamous cell cancers. Many of you may have heard the term. They arise from the lining of the throat or the mouth. And then as you go deeper, you may have tumors that come from the salivary glands in the same area. And you may have tumors that arise right under there from the bone or the soft tissue. So it's a very complex and varied kind of mixture in terms of biologic behavior, or how these tumors behave in terms of what is their ability to spread to other parts of the body, and how would you end up having to control them. So it requires a lot of understanding of the biology of the tumor, how they behave, rather than just being able to either do an operation or to prescribe radiation or some other sort of treatment. So it's a multidisciplinary team that you need in terms of trying to understand what exactly to anticipate in terms of behavior of the tumor.
So you need that team. It's not just the surgeon. You need
that is absolutely right. So it's a comprehensive understanding of the behavior of the tumor, and each member of the team has to be pretty much on the same page in terms of deciding how to treat that patient.
So Dr. Ganley, is surgery or the surgical removal almost sometimes usually the first step, or does it depend on the cancer as to what's the first step here when someone presents with or is diagnosed with a head and neck cancer?
Well, the surgeon's main role is in diagnosing and investigating any particular cancer of the patient that comes to our clinics. And then once we establish a diagnosis, which may or may not require us having to carry out a biopsy on the patient, we will then work with our medical and radiation oncologists to come up with a team approach to how best to manage these cancers. Now, the actual approach that we decide on is very much dependent on the location and on the type of cancer. So, for example, thyroid cancer is very much a surgical disease. So that's very much controlled with surgical resection. And then afterwards, our endocrinologists who specialize in thyroid cancer would be involved in giving radioactive iodine. Medical oncology and radiation oncology really have a much less involvement in those types of patients, unless the patients present with very aggressive forms of thyroid cancer. On the flip side of the coin is a cancer such as cancer of the nasopharynx. That's a cancer at the back of the nose. And these cancers are surgically extremely difficult to remove without causing significant cosmetic deformity to a patient's face, and also have a huge impact on the patient's function. So as a consequence of that, these cancers are largely controlled with chemotherapy and with radiation therapy.
As opposed to going right in and trying to surgical removal.
Yes.
And is there a middle ground somewhere where you do both surgery and radiation?
Yeah, exactly. So a good example of that would be cancer of the voice box. That's cancer of the larynx. So in early stage cancer of the larynx, the patients have a choice of treatment. That can either be with surgery, which nowadays involves laser surgery, and the alternative to that would be to have radiation. So the patients will see myself and Dr. Patel for the surgical opinion, and then they'll see our radiation doctors for a radiation opinion, and then the patients, along with the physicians, will then determine what's going to be the most appropriate treatment for them. Now, for advanced larynx cancer, these patients in the past, up until the end of the 1990s, were largely treated with total laryngectomy. That means removal of the voice box.
The whole voice box.
Yes, but since the introduction of chemotherapy and radiation, many of these patients now are treated with chemotherapy and radiation, and surgery is largely not done now for these patients.
And that allows them to maintain their voice?
Yes, yes, unless the radiation and chemotherapy fail to work.